So we now have some time to take some questions and discuss the element, I suppose, of detection, deterrence and enforcement in the context of this complex issue. And Mark is right off the bat probably going to tell us that this is all a waste of time.
No, just the opposite. I really want to compliment all the presenters on very interesting data. Professor Cameron, I just that kind of analysis is what I love to see. So I was very impressed with it. Let me push a couple of questions on that, though. It seems to me you've got a benefit cost analysis that has all of the social benefits counted and only a small fraction of the costs. So you've got all of the public budget costs of the officer's time and the testing activity. Don't include the budget costs of the arrest, trial, and punishment that follows, which are going to be substantial in the small number of cases where it happens. An arrest is probably a $1,500 activity. A trial is probably a $15,000 activity. A prison sentence, God knows. But also not counted is the time and inconvenience of the driver randomly stopped. My guess is the minimum willingness to accept for that would be on the order of $25. Might be higher than that. So if you put in all of the costs, I'd like to see where the cost-benefit numbers come out. But doing it a different way, given how astoundingly cheap a breathalyzer is, if you applied those same dollars to doing more random breathalyzer tests, what would the safety impact be? So there's a cost-benefit question about the program you looked at. There's also a cost-effectiveness question compared to doing a different program with the same resources.
Thanks.
Yes, I only last night was looking through the Druid report that was provided yesterday, and one of the issues I noted that they included in their cost-benefit analysis was the cost of the driver time at the roadside, and I think that's something that should be included in such a benefit cost analysis. It's particularly up in mind for me because I've been doing similar analysis in the speed enforcement area, and you could argue that reduced speed limits and enforcement of existing limits increases travel time, and in Australia we tend to want to ignore that sort of thing, but I don't think it's totally fair. I don't know enough about the additional costs of processing the offenders. In Australia, we do use a lot of administrative adjudication. We proceed through traffic infringement notices, whereby if a driver accepts that he is in a sense pleading guilty. So that makes the process very much more efficient. I think I've covered all your questions.
I guess something I should have mentioned but didn't mention is the actual cost to the person punished of whatever that consequence is, which ought to go into the equation someplace. But the other question I asked is, so you've got a public budget cost that you estimated at something like $130 per random stop. Is that the right number?
141,
right.
In fact. Yes.
Okay. So if I spend $141 on breathalyzers at the roadside, which probably cost single digits of dollars each,
Yep.
what would my marginal traffic safety improvement be compared to what I get by spending that $141 on drug tests?
The material I presented here today, in fact, was based on a paper I presented at the Alcohol, Drugs and Traffic Safety Conference last year. And there was a parallel paper about best practice in random breath testing. And I attempted a similar benefit cost analysis looking at the marginal benefits of increasing to different levels. And I think you need to be looking at almost 3 times escalation in the amount of random drug testing done in the state of Western Australia, which has about 1 test per 2 licensed drivers, before the marginal benefit cost ratio falls to around 2. So I think the general message is that taking the investment resource and investing it in more random breath testing rather than random drug testing is not a good investment. At the margins, it's better to put it into random drug testing. At this point in time, in the Australian jurisdictions, where we still have a substantial drug driving problem, and the investment is worthwhile. very worthwhile.
Gordon?
I would add that this is taking place in an area that probably has the best saturation in the world of drunk driving, random breath tests and things like that. So the model is not quite so applicable to other countries, which is I think what you're looking at in terms of I don't know anywhere that's getting anywhere near your levels of testing rates for random breath tests.
No, that's entirely true. Australia leads the world in terms of levels of random breath testing in all jurisdictions, and I guess we do in random drug testing as well.
You're already on the diminishing returns part of the alcohol testing.
Exactly. The curve I showed is that the alcohol testing is down that bottom end. It's still a worthwhile investment because of the minimal cost. But the random drug testing is in the steep part of the curve, and even though it's expensive, you get benefits exceeding costs.
Dr. Cameron, just a more trivial cost question. It seemed to me like your costs for the Secure Tech and COSART and stuff were really extraordinarily high, as well as the laboratory costs. And that's, if you're trying to, and those are the most visible components of it that people understand is drug-related.
Yeah, those costs were quoted to me by the Western Australian Police.
No, I don't doubt that that's what they're paying, but I think other places are paying a lot less. So
there could be economies of scale, but I would have thought we'd be in that arena in Australia.
I think you're just making a lot of money off of you.
I see, yeah.
And
That could be true. And that's why I was interested to take the recent Victorian government announcement of 4.3 million for an extra 50,000 tests. And that turns out to be, what, $86 a test. I'm not sure what's included in that figure, but it's in the same ballpark.
May I ask another question of Amy? No, I was just interested in your models analyzing what variables were most predictive from the DRE. And I've heard a very important component of many drug calls is what the offender says to the officer, the confession, so to speak, and that they get a lot of the calls are based to a large extent on that. And I didn't see that coming up in your predictive model. But mine may be just a hearsay, just a fabrication.
Is this on? It's a good question, John. I wasn't, in the models that we looked at, we didn't look at that particular variable, but we've done some subsequent research, which I didn't present today, but we've actually found that when you look at the relative predictability of clinical indicators, performance on divided attention tests, the observations of the subject and any statements made by the subject, it really does, it's really not, doesn't have much predictive value. I think in a lot of cases the suspects will lie during the exam. No, that's what, so I think that's, you know, I think it's important to take that into account as part of the evaluation, but from some of the research that we've conducted, it's really not playing a significant role in terms of predictive validity in the model.
Is it conceivable that it parallels the predictive component of some of the other more objectively measured things, and that's why it's already covered by that?
Well, in the models, we've parsed it out. So we did a stepwise logistic regression. So the unique variance was separated. So it wouldn't have been, there wouldn't have been any correlation between the two. That all would have been separated out in the model.
Ross?
I might address Mark's question to Kerry then. Is it worth New Zealand putting more effort, increasing its effort into drink driving than drug driving? Have you got a sense of that?
Yeah, thanks, Ross. It's something we'd need to do some mathematical analysis on. I'm not certain where New Zealand is in terms of the diminishing returns around investment. One of the things that sits in the back of my mind is in the ideal world, we'd get additional funding to do a drug program on top of what we currently do. But within a constrained fiscal environment, one of the questions is going to be if you, say, pull $5 million out of alcohol testing and put that into a drugged driving program, are we going to get a benefit from that? Or because one of the concerns that I would have is to focus on a problem of drugs driving, as we would potentially see more alcohol-related crashes and harm arising from that. So the bottom line for me is harm reduction rather than causation per se. So what I'd really want to see is the harm reduction coming from it, whether that balances out. So that's something we'd need to do some work on. I'm going to grab Max later and have a talk to him about his sense on that.
Just in response to Mark's question around the costs to society, the UK's impact assessment for our new offence did take into account all the costs, including court costs, costs to the driver for inconvenience, costs to the pharmaceutical industry for amending all the patient information leaflets. And offset against the casualty savings, we found that there would be a negative cost to society of £79 million over 20 years, which you might think, well, why the hell are we doing it? Our politicians took the view that despite the costs to society, it would still be of benefit if we did deter people from taking drugs in the first place, which we haven't calculated because we don't know to what extent that might happen. But there was some analysis of total costs done in our impact assessment. I have a further question. I just wanted to clarify. In Victoria, do you have, it's per se or fluid limits? Is it, or is it just merely the presence of?
It is a per se in that the prescribed concentration of a prescribed illicit drug is 0. Right. So it's a total prohibition.
And do you not have any issues around accidental exposure, defence lawyers claiming passive inhalation for zero tolerance?
No, not at all. And that gets back to some of the things that have already been mentioned about the capacity of the device to detect it, at what levels it detects. And your confirmation analysis level is at a scientific standard. It complies with the Australian and New Zealand standards for the measurement of substances in oral fluid, which is at a set level. So, and it's a very important concept or notion for us in terms of we as a government or a policy-making body would not and could not prescribe a legal level of an illegal drug. So that was, and we've adopted this process, and it also mirrors our prescribed concentration of alcohol. We set a limit, and our prescribed concentration of alcohol for our novice drivers is 0, but there is a tolerance in terms of what level we charge at. Okay. There's one up the back.
This is a question for Philip, I guess, which is some of the things we were seeing yesterday were indicating that a driver using cannabis alone was looking at around sort of a 2 to 3 time increased crash risk. But I think from your slide, it looked like your data showed a higher crash risk than that. So can you just clarify?
That original culpability odds ratios. From memory, the average delta 9 concentration of bodies in the morgue was 42 nanogram per mil. It's like alcohol. The people who end up in the morgue got very high doses.
Question down the front. Paul?
So this may be a bit of a naive question, but to what is there if you want to get prevention, I guess what you want is what's important is people's perception of risk. How is that necessarily, and is it linearly associated with the number of tests you do? Or I guess another way, can you increase the perception of risk without necessarily increasing the costs that you spend on tests?
I can comment a bit on that. I think there is a relationship, but it can be magnified. And we see that very well, I think, in Victoria, where we have mass media publicity for road safety on a scale that you can't imagine. It really is quite unique. They decided many decades ago now to move from the traditional government-funded, low-profile Mickey Mouse road safety advertising to something that competes with brand advertisers, Coca-Cola and McDonald's. And all Victorian residents are bombarded with advertising, and it's not just on television and radio, but also billboards and newspaper. And all our research suggests that it has a magnifying effect. And while the random breath testing has a high profile at the booze buses, it's also practiced from small cars in back streets, which doesn't have a profile. So all that needs to be magnified. But I think it's also true, the more you do, the more impact you have.
Probably something I can add to it as well is we see it most dramatically around speed. So there is a direct correlation between volume of tests in terms of volume of breath tests or volume of enforcement stops or infringements issued, between that and behaviour. But we, as an example, last summer, so the summer of 2013 to 14, we lowered the speed enforcement threshold in New Zealand, or the tolerance, and we did that for a 2-month finite period with extensive advertising aimed both internally and externally. And what was really interesting was to look at driver behaviour in terms of the proportions of people speeding. So the proportion of people speeding of up to 10k over the limit, as surveyed, dropped by around 35%, but the proportion of people exceeding the limit by more than 10k's dropped by 46%, and that correlated to a 26% reduction in deaths over that period. And I'm conscious that correlation is not causation, but a paper's just been presented on that, and a lot of that rested around changing that perception of apprehension for the average driver who changed their behaviour to suit. Because what happened, though, is once the campaign ended, the behaviours almost immediately reverted back. So whatever you do needs to be sustained. I often say what we're trying to do is mess with people's heads, because their perception of risk of death or injury is really low. So a lot of this at the individual level, if you double the risk at population level to an individual, it's still incredibly small and they think you're full of it. But if we can do it at the population level and get people understanding, that's really significant. So what we're trying to do is achieve these population level changes. So advertising is incredibly important, and we do see the results of that.
Any more questions? Mark?
If I might make a comment as opposed to a question. So this has all been about detection and deterrence as a consequence of detection. We haven't talked much about the consequences. Those are essentially taken to be fixed by the statute. But it seems to me the example of South Dakota 24/7 suggests that a good consequence to administer for driving drunk is not being allowed to drink. With the other drugs, that'd be very straightforward to do. Okay, so here's your first drug driving offense. Here's your fine. You're coming in once a week to have a sweat patch put on, and you're going to do that for 3 months, and it's got to be 0 or you're in real trouble. And so the consequence of driving drugged is you're not allowed to use drugs. That seems to be a pretty good deterrent for that group. Appropriate, relatively non-invasive, relatively low cost. It seems to me if we focus entirely on making people's lives miserable, and the estimate in the U.S. is that the personal cost of a drink driving conviction is about $10,000. That's certainly appropriate for somebody who makes a habit of it. Whether it's something you want to do to somebody who did something stupid once, it's a different question, and one we ought to explore. We'd be looking for the minimum effective dose of punishment that will change behavior.
Just Chairman's prerogative, I just would like to respond to Mark's comment. We have a process where our enforcement model is moving much more towards involvement of a therapeutic justice component. And to the extent that we've now got a pilot program going where we have for want of a better term, a DUI court as well as a drug court for the more serious recidivist type offenders. But on the other end of the scale, a first-time drug offender in Victoria gets a ticket for $460 and their licence is suspended for 3 months, and to get their licence back they have to do compulsorily have to have an education component course. That's the first stage at the lower level. As it gets, if they're recidivists, then it goes up to the higher standard of behaviour and treatment of the condition itself. So, so what I'm saying is I agree with you, and our jurisdictions recognise that, and we're importing that into our process. Question over here.
Good morning, thank you. Kerry, my question's to you. In regard to the testing, if we were to follow a similar pattern to Victoria, would we be looking at other substances as well, apart from the 3 illicit ones? Would we be looking at sedatives or opiates or...?
One of the challenges you get with a roadside screening regime is we've got drugs that shouldn't be in people's bodies, so the illegal ones. You're talking generally Schedule 1 and 2 of the Misuse of Drugs Act. And then you get drugs in people's bodies that can be there quite legitimately at therapeutic levels. So things like opiates, benzodiazepine, a range of antidepressants can be there in therapeutic levels. So one of the things that will need to be considered as part of the development is what are the drugs that need to be tested for that will have the greatest impact on the population behaviours. So Australia's gone down the big 3. If we go down a route of testing for a wide range of drugs, we're going to be pulling people in for quite intrusive testing who have therapeutic levels in their blood. So it's something that will need to be considered. There is the possibility to test for a wider range of drugs at increased cost. What I'm most interested in is really what is the minimum number of drugs we test for to get the outcome, which is less drug-related crashes. So I haven't got an answer yet because we're a long way off that policy development, but it's something we need to consider.
Just with synthetic drugs, synthesised drugs, we looked at yesterday some synthesised drugs which are rising. Could that be impacting that our population could move towards those undetected synthesised drugs?
That's a potential risk. Saw a recent presentation on the things like the synthetic cannabinoids or analogues to the cannabinoids that will cause similar effects that would currently not be detected. I don't know at this stage what the testing regime would look like and what we would need to test for. I want to see a really solid base of what is the risk profile and then what can we do to ameliorate that risk. That is a risk that we would need to consider as part of this policy development, though.
Yes, because you were referring to the ageing population as well and the sedatives. And I work in a drug unit and we have a lot of illicit use of these substances, but these won't be tested?
If somebody failed an impairment test, so if you have, for instance, a cancer sufferer on opioids for pain relief, and they were taking a non-therapeutic level and they turned up at a compulsory impairment test, potentially they could be picked up for that. I think that's the tip of a very large iceberg. There are people out there using therapeutic drugs at non-therapeutic levels, and I don't think we've got a handle on the scale of that at all.
Like oxycodone and...
Yep.
Which is right, the use is rising, the prevalence of use is rising of those medications in New Zealand.
Yes, and as we age, we will see more people on therapeutic drugs, which part of the conversation we're having at the moment with NZTA is around how we improve our medical referrals and improve the knowledge of our doctors around the effects on driving from the use of therapeutic drugs particularly at high levels. There's some big challenges.
Could it be that this is an easier target, the 3 illicits?
One of the things that I think will happen with a drug testing regime is what the public will hear is the cops are out there, they're stopping everyone, they're testing for drugs.
Oh yeah, that's the illicit drugs they're testing for.
Yes.
Yeah.
Yes, but what I think though is people will hear drugs and you'll get a behavioural modification from that. You'll get people who carefully weigh what they can or can't take, but we'll also get people who just hear cops are testing for drugs. They don't know what we test for. So there will be an effect from that. To what extent though, I don't know.
Yep. Because if I'm right, the Victorian testing's gone up, but the death toll's still gone up as well. Is that correct?
Well, yeah, that is correct, but there's a lot more factors in this complex issue that need to be understood. The prevalence of methamphetamine in Australia has doubled over that period from 2009 onwards. And so there are other factors that influence what the detection rates are and what impact that has on road trauma. So it's important to have a really good understanding of what's going on in the environment of drug use as well, because it does, that road safety and the war against drugs does overlap to some extent.
There's been some easing on the war, though, internationally in a lot of places.
Yeah, well, that's right.
Yeah,
I use that in inverted commas, the war
Yeah.
against drugs.
And
There are
we've
two issues.
learnt about the word, I think, yesterday was fairness and justice. Fairness? Because this doesn't seem fair. I don't know. I might be wrong.
Well, it's not fair for people to be killed by drug drivers.
I know, I'm just about the selection of drug drivers. That's what I'm thinking about, rather than medicines and other substances that are prescribed. Yeah.
Yeah, well, so I can only talk on our structure in Victoria, and our illicit drug strategy is based on, for testing for illicit drugs in road safety, is because those are the three drugs that are most prominent in our road trauma. And it's a behavioural change process. We do have the other process, like the compulsory impairment testing for all the other drugs, and we do detect people with misusing prescription drugs. There is a statutory defence in terms of if they're using their drugs in accordance with their medical practitioner's advice. They don't get convicted, but they still are prohibited from driving, and there's a medical review conducted about their driving licence. So there's a whole range of things you can put into place, and I think that's the fear that communities have. Is that it's a whole set of, these are the rules, and there's no consideration about how that affects society as a whole. But we've spent a lot of time. One of the things that we spent an awful lot of time and money on was to take amphetamine out of our tests, so that we only specifically focus on methamphetamine, because of those people that have ADHD and things like that use prescribed medication containing methamphetamine. So we didn't inconvenience them. So there was a whole range of interest groups and things that had to be negotiated with and discussed as to how this was going to work. And at the end of the day, it gets back to the comment that Kerry made. It was about separation of behaviour. We're not debating the moral argument of whether you should use drugs or not use drugs. What we're saying is, don't do that and get in a car and drive, because you represent a higher risk than a drug-free person.
Max has a...
Oh, sorry, Max.
To support Kerry's expectation, one of the things I showed you was that as the random drug testing increased up to 2009, the proportion of drivers with any impairing drug, that's in addition to the 3 prescribed drugs, amongst fatal drivers, also fell. Now, the people who have an impairing drug but aren't one of the 3 impairing drugs, prescribed drugs, aren't the target of the enforcement. But it would seem that they thought there was a threat of detection, and they changed their behaviour. And this, I think, while you may not think it fair, is a good thing in road safety terms.
Jane up the back's been waiting for some time.
Okay. We need to move on, but for the record, I disagree, and I don't want everybody to think that this is what this came out of this meeting, but Mark's comments about just quit doing drugs flies in the face of over 50 years of very solid research on addiction and withdrawal. And if people could just stop doing it, they would have. We know that addiction is a brain disease, and the research gets more and more solid on that. So he's entitled to his opinion, but I wanted to speak out that there's certainly the literature to contradict that.
Following on from that, I think, is an interesting question as to what the penalties are and what interventions you introduce after the police have done their fine job of picking these guys up. Because at the ICADS conference, there was some evidence that a lot of people who have a licence ban continue to drive, and a lot of people in New Zealand, for sure, don't pay their fines. So we end up in this process of catch and release and the problem continuing to go back on the road. And I guess the question is whether there is assessment of addiction issues, whether there is assessment of what the appropriate intervention is for that person. Once we've actually got hold of them, do we assess them? Do we give them the correct intervention so that their behaviour then changes? Obviously, there's the wider public that we want to deter who don't do it in the first place. So that's a big effect. But I guess what I'm saying is once we've actually got hold of these offenders who have been detected drug driving, do we have a good science about what to do with them once we've got them?
Does anybody want to speak on that? Yeah, Kerry?
I think they're really good comments. One of the things that we're doing in Australia, and this isn't in relation to drug driving, this is in relation to alcohol and people who go on alcohol ignition interlocks. We're looking at a tiered model. So if you're a first-time offender, low range BAC, you may be direct, and this isn't in place yet, we're actually negotiating this. You may be screened to then go on and do an educative program or an awareness campaign. Once you then become into the recidivist area, so you're being picked up a couple of times, the plan is to start screening for alcohol problems. We're also negotiating to screen for drug addiction as well, whether that even be illicit drugs or pharmaceutical medications. From there, you can then, if it's high risk, it's not just about things like saying, well, here's your punitive suspension, here's your interlock or anything like this. You may actually be directed off to go and do a treatment program. You may actually be directed. There's still an enormous amount of policy implications surrounding all of this. And then we actually don't have this model in place, but we are working very hard across all Australian jurisdictions to see how we can actually get this in place for at least alcohol, and then somehow we might be able to bring in the illicit drug with that as well.
A lady in the middle there.
Thank you. Hello. Now I realise this might be a bit of a brave thing to do, to start talking about anecdotal evidence in a room with so many scientists. But my question's for Kerry, I think, but perhaps someone else can answer it. I've noticed that in a lot of job applications, or when they advertise for jobs now, people often require employees to undergo drug testing as a condition of employment and ongoing. So I guess my question is, has any consideration been given to the role that private employers are playing in this deterrent effect?
Is this from it? Yeah. If you don't mind, I'd actually like to refer that one to my colleague, Professor Jeremy Davey, because he actually does all the work in this particular area. I'll put you on the spot, Jeremy. Yeah. Yeah, no.
So your question is saying, in terms of employment, has the employment issue of drug testing on work sites, etc., has an impact on road sites? We work, in some of our states, for example, Queensland, which is a large coal mining, people are breath tested on most coal mining sites. People are breath tested every day. Every employer is breath tested every day, and a percentage of up to probably 50% of some of those workers on some sites are drug tested every day. Those programs, in terms of people on site, have been very successful in ensuring that people don't get through the gate, right? However, what we have found in those communities, we are still finding the same levels of drink driving and drug driving. What has happened, in a way, it's people have started to separate. If you are using alcohol or if you are using drugs, you don't go to work, you don't get into the work site. So we've separated the behaviours. We haven't necessarily separated those behaviours then on the road when they're driving a motor vehicle. Ideally, in terms of it, and this is part of if I go back to drink driving again, which Australia is probably one of the world leaders in terms of the process that actually happens with random breath testing. And this is Mac's work about diminishing returns. If you breath tested everybody all the time, every day, during the day, we could even more ensure that less people would be on the road intoxicated, but we actually can't do it. So, in a way, and this is what at our Deterrence, and it was Kerry's paper, about we're trying to separate the behaviours. But your answer is yes. We've made all those workplaces that actually have a gate and they test people. People don't come on site because they physically can't get on site, and they've actually been very, very successful in terms of the number of positive tests they get compared to the number of tests they do. But people have made that separation, but they haven't taken that behaviour to the roadside. We still get the high levels of drink driving, the high levels of drug driving.
Just a comment. Comment on, I'm not sure if that's on, a comment on your workplace and going through the gate. One of the programs we introduced in Victoria in 2003, May, is the alcohol interlock program, and we've installed over 40,000 interlocks. And now we've just moved to make every drink driver offender, first offender, gets an interlock. So they do get tested every time they want to drink it, every time they want to drive their car.
In Victoria, because you're also.
And again, it's interesting. Some of the interlock research shows when the interlock goes off, people start to drink again too. So it is about this constant program of managing it, and I think that's also on one of the stuff is you've got to be constantly managing this. It's not a matter of a one size fits all and one inoculation shot fits all. It's a moving target the whole time. And the beauty about it is, and that's why we work in the areas, was we're dealing with human behaviour. We're dealing with humans, and they're very they're predictably unpredictable. And they'll weave and dodge and find the weakest link.
Okay, perhaps one last question before we break. No, any takers? Sorry, yep.
So I'm still slightly unsure, and I apologise for my lack of attention, to the extent to which the outcome measures of the number of drivers found with drugs in their system, either injured or deceased, was associated with the number of testing. And then the suggestion later on that when it wasn't, there was confounding variables. So how strong is the association, and what are the and what sorts of confounders do you look for? And obviously you can't just take into account things when the relationship isn't there than when it is. So how robust is that evidence, I suppose the question is I'm asking, in terms of the relative number of tests you're doing?
Well, this is not really my field, but we based our roadside alcohol testing process on the research done by Hommel from Griffith University back in the early 80s, and that was the research that he did suggested that it had to be a 1 in 3, so one test for every 3 licensed drivers. More recent research done at QUT, Queensland, or CARS-Q, suggests that there's a better outcome for a 1-to-1. So we've taken that on board for alcohol, and we did in 2012 we did 3.94 million roadside screening tests, and we have about 4 million licensed drivers. So we've moved to that almost. It's about 1.2 ratio ours is, but it's about 1. We're trying to go to that 1-to-1. With our drugs, we're using the analogy that we're talking about a deterrence program, and we're focusing on those people that use illicit drugs for social purposes rather than dependent people. Applying the same methodology, we're looking and using, and the data's not as clear as it should be perhaps, but about 15%, our household surveys tell us about 15% of our people are using illicit drugs. So we apply that to our licensed drivers. You end up with, basically we need to be doing at least 200,000 tests to get a 1 to 3 result, or we have to go up to 600,000 tests a year to get that 1-to-1 potential driver ratio. So the research tells us there is a relationship, although it's not as clear.
In the accident data?
Well, I can give a good example relating to alcohol. In about 1996, I think it was, for various reasons, mainly political, we reduced our high visibility, high volume testing. And as soon as we did that, our road trauma increased. So there is a definite relationship between the number of tests and you have to sit with that number of tests, the exposure to the community that we are actually testing. And a very important part of that process of testing is the credibility. So that if we say we're going to be out there testing, we need to be out there testing, and when we do catch people, they have to be sanctioned. And the principles that Hummel enunciated back in the 86, I think it was, he released his research after introducing random RBT in New South Wales, is what we've faithfully stuck to the whole time, and it's worked for us.
Can I comment? I think what Paul's driving at is how strong is the cause and effect relationship that we're implying. And the results I showed you for the period 2005 to 2009, when random drug testing was introduced in Victoria, was a relatively stable period in a whole range of dimensions, including the way the police were operating. And of course, I also showed you that in 2010 onwards, things changed, which would cast some doubt on the cause and effect relationship. I think it is early days. We do need to extend that type of research and consider other potential conflicting variables. And it reminds me of how we looked at the increases in random breath testing in the early 1990s when it was escalated quite substantially through the use of booze buses. But it also turned out that Victoria was having an economic recession at the time, and economic recessions also reduce road trauma. So we had to build quite sophisticated econometric models that in fact took into the account of a whole range of other variables. Travel patterns changed in the metropolitan areas relative to the rural areas and so on. So it is doable. I think it's fair to say it hasn't yet been done thoroughly in the random drug test area.
Okay, well, I think it's 2 minutes after the appointed hour, so I'd like to, if you join me in thanking our presenters this morning.